afternoon, everyone. Thank you very much for showing interest in a talk around digital. So hopefully it will be relatively interesting, and I'm going to cover a wide variety of different topics. So just a quick introduction to myself. So I used to be an NHS academic trainee in nephrology, and then I worked in sort of NHS transformation in services across Northwest London, and now I'm one of the co-founders of a company called Aviva, and we're a company on the NHS Innovation Accelerator, which is a scheme designed by the NHS looking at adopting solutions that have proven benefit in the NHS at scale. And the sort of the brief background to Aviva is it was sort of inspired by a pediatric endocrinologist working in type 1 diabetes education. And the challenge that he saw was children that they were educating around carbohydrate counting and their medication dosing he was really struggling to engage them in their care. And what he did notice was that they were all staring at their smartphones. So he thought, why don't I try and deliver the advice and the education that I'm doing through their smartphone rather than face-to-face clinics? And we kind of as a company have taken that forward to say, how do we deliver kind of all behavior change interventions around diet and lifestyle and kind of use technology to scale existing services? So I thought I would start just on the challenge that is faced. So at the moment, the statistics are 64% of UK adults are either overweight or obese, and 9% of UK adults have diabetes, of which 85% of people with type 2 diabetes are either overweight or obese. So there's a very strong challenge both across local authorities and CCGs in terms of it's the same driver that is driving the healthcare cost as is also sort of as part of public health budgets. And this cost overall of those conditions, so diabetes and obesity related conditions, cost the NHS at least £16 billion per annum, which is a large proportion of the budget and growing, as I'm sure we're all aware. So it's not just health costs that are related to diabetes, but it's also the system at large. So lost working hours from diabetes alone are estimated by Diabetes UK to cost £9 billion per year to employers. And the other statistic, not just specific to diabetes, but people who have long-term conditions on average take 10 days of sickness absence per year compared to just under 3 for people without a long-term condition. So it shows the importance of sort of population health management is not just a health problem or a local a public health problem, it maps across the two. So in 2002, the Oneness report, and then in 2010, the Marmot report talked about increasing investment in primary prevention, and then the 5-year forward view further stressed the need for a radical upgrade in prevention and public health. So my first question for the audience is, how much has public health funding gone up between the year 2000 and the year 2017? Anyone want to make a guess? Public health funding in that period of time. It was, well, I can give you, it was 1 billion in 2000, and it has gone up. I'm going to show you on the next slide, but any guess? No? Okay, what about health funding? So health funding in 2000 versus public health funding in 2017. So, this wonderful slide. So you almost have to get your magnifying glass out to see the public health spending versus the total healthcare budget. So public health spending has gone up from 1 billion to just under 4 billion, and health spending has gone up from 50 billion to 143 billion. And I think a number of reports now have talked about the importance of prevention in tackling this sort of growing demand of long-term conditions. But really interestingly, funding has not followed this trajectory and has not followed the rhetoric of the reports and what we need to be investing in. So kind of to achieve this radical upgrade in prevention, I think so there's two ways of kind of thinking about how that could happen. So one is thinking about new approaches to funding, and another is new ways of thinking about delivering services. So as we saw on the last slide, public health funding remains extremely limited, increasing the pressure on CCGs. And there's also lots of evidence that face-to-face interventions can be very effective for type 2 diabetes and for obesity, but they've shown a limited impact at scale because there are people not accessing the services for various reasons. Say they're working age populations, carers, people with young families, people with mobility issues, whatever it may be, aren't able to access services. And then there's also cost effectiveness questions around the loss of the face-to-face services, quite often because capturing outcome data is not always an immediate priority, and so that sort of combination of capturing the outcome data and showing the benefit is key. And then the last thing is that there's a real workforce question. So in the UK today, there are 8,000 registered dietitians, of which only 4,000 work in the NHS. And it's a 97% female profession. And a lot of people leave the workforce to have children. And there's very, very few flexible or remote working options for dietitians to re-enter the NHS. So you could argue, you know, the most trained healthcare profession in terms of behaviour change, especially around nutrition, are not able to provide those services because of the ability for them to regain the workforce or rejoin the workforce. So one potential new approach to funding is pooling council public health and CCG long-term condition budgets. And the reason kind of why sort of I mention that is the sort of a population health model approach is emphasized in actually so ICS rather than ACS models, looking at sort of how do you target high cost conditions across the population. And then also, when we work in obesity services, there's always a silo between tier 2 weight management and tier 3 weight management, but in reality, it's just a continuum of care. So the idea is how do you think about commissioning across that population? And so we work in Buckinghamshire, where this is already happening. And I've actually had quite a few great conversations earlier with people today talking about how the Health and Wellbeing Board have public health people in the CCGs to be able to think about that kind of integrated commissioning model. And then the other way is thinking about new ways of delivering services. So thinking about digitally enabled or remote services to do disease management and to do behaviour change. And we see there's kind of four main benefits of changing the delivery model. So one is access, simply because you don't have to travel to a venue. It's not necessarily done in working hours. You don't necessarily have to arrange childcare or carer support, whatever it may be. A second massive piece is outcome transparency. I think sort of value-based payments and value-based care is something that everyone is striving towards, but it's very hard unless you know the impact of the intervention that you're having. So it's really important to measure that and see what the benefit is. And there's lots of data around potentially superior outcomes to just face-to-face group care from the published data. There's also lots of evidence around cost effectiveness. So instead of having to have very expensive venues, transport costs, the travel staff time to do that, if people are doing things remotely and with technology, you can try and make the services much more efficient. And then there's also the potential of being able to cover the workforce gap. So if you can offer roles to dietitians or to diabetes nurses or to COPD nurses or whoever it is, if they can counsel the patient remotely and work in a flexible manner, they can come back into the workforce rather than being sort of restricted to a face-to-face only model. So why do we need new approaches? I would put out, this is slightly unfair on Desmond, but it is the evidence base today. So Desmond is probably the most commonly commissioned type 2 diabetes structured education program in the NHS. In their clinical trial, they show no benefit in weight, HbA1c, cholesterol, blood pressure, or medication needs. And also the NDA data shows that about 5 to 10% of referrals uptake the service. So of the 300,000 or so newly diagnosed type 2s each year, it's around 7% of them are accessing structured education, which is a huge issue, because all of those people, if they don't learn about their condition, they don't learn how to self-manage their condition, they're going to be able to not be in a position to improve their health as much as they could be. And so we really need new ways of offering solutions to people who can't access those services. And actually just one last point on this. There has been a huge amount of research in terms of the barriers to access, and a lot of it is things like stigma in certain populations. A lot of it is just around the cost of attending for people. So there's actually really well-known barriers to what the challenges are. It's just there hasn't been much change in how we've delivered things. So second question of the day: how many food decisions do you think you make per day? Anyone? Anyone want to hazard a guess? 20. Any others? 50.
60.
Unfortunately, you're nowhere near. You need to increase that significantly. Yes. So there's been lots of research around how many food decisions that we make each day, and there's conscious and unconscious food decisions that we make. And so if you're making 200 food decisions each day and you're in what is commonly referred to as an obesogenic environment, being able to give people the knowledge and to be able to make decisions is a very important first step. But another kind of big issue is around choice fatigue. So there's been lots of research in sort of the growing field of behavioral economics, basically talking about how people don't act rationally. So for example, in pensions is always the classic example. If you make it opt out rather than opt in, people are much more likely to do it. And one of the big things of behavioral economics research is choice fatigue or choice paralysis. So if you give people too many choices, they're very likely to go to the default option, which is why opt out is quite effective, because then people just stick with the default. And that is the massive issue with food and eating. The Eat Well guide, I think most people would be relatively familiar with. Food labels are quite clear in terms of what's healthy and what's not. But there is a real choice fatigue if you're making so many decisions each day. How do you know that you're making the right decision? And how do you get the support to help you sort of get over the barriers to perhaps changing your diet and lifestyle? So another thing is we are also living in a very different era. So this is from America, but I imagine you'd be able to find exactly the same thing. So this is people in a fast food restaurant, and every single person, apart from one lady in the middle, and almost everyone in the background, is staring at their phones while making a food decision. And so if you can engage people in their phone when they're thinking about food decisions and their food behaviors, you might be able to have a powerful and strong impact. So next question: what is the fastest growing age group for smartphone use in the UK? Ooh. So I have one data source from it is from Statista, who did the actual analysis. It's actually Ofcom data, but it is 55 to 74-year-olds. So if you look on the far left, 2012, it's 9% of 55 to 64 and 3% of 65 to 74-year-olds were using their smartphones. And then if you look in 2016, those groups are dramatically catching up. And if that trend continues, you're going to have as much smartphone use and engagement in that population. And interestingly, that population is the key demographic for long-term conditions. So that's the age group that starts to develop conditions like diabetes, conditions like COPD, and something that from a prevention view of the world is really, really important for us to engage and to work with. So, question of what types of new approaches are effective? So I'm just going to go through a couple of the approaches that have been tried, and just of a straw poll of people, what people would vote to think that solutions that are only digital are effective. So whether it's a Fitbit on its own, or whether it's just an online portal that people access, and what the evidence base is for that. Do you think that that drives a benefit or not? Hands up for yes. And what about if you provide someone with digital or online materials and you also have access to a healthcare professional, be it a nurse or a dietitian or something similar? Hands up if you think that provides an additional benefit. Very good, basically. So Digital only solutions. So there's been quite a few relatively big trials now of this. So the first trial is a huge trial looking at using activity trackers in weight loss programs. And they actually found if you add an activity tracker to a weight loss program, you actually decrease weight loss in the people who have the activity tracker. And there's a number of reasons why that could have been the case, but it was a very interesting finding, and it's the biggest trial that was done to date. There was also a very big trial of using MyFitnessPal, and using it alone was shown to have no benefit. And the digital only, so there's something called the Power study, which I think quite a few people are familiar with because it was done in Southampton, and they had an online only option and then an online only plus a very moderate amount of nurse support. And with that, they were able to show some weight loss, but there wasn't any in the digital only arm. So then there has been a number of studies done combining digital and HCP support. So all three of these are actually dietitian-led interventions, but it's true in other areas as well. So it's basically comparing remote dietitian support with face-to-face support. So in the first study, it was comparing outcome equivalents between face-to-face and remote dietetics, and it showed that they're equivalent. The second paper was doing remote dietitian plus a digital learning program and showed really good weight loss. And then the last one was comparing low and high frequency support. And really importantly, it showed that there was quite a big difference between high frequency support and low frequency support. So if we're going to provide any intervention with digital, you can provide high frequency at a relatively low cost. Whereas if you're going to do high frequency in a face-to-face model, that is very expensive. And so there's really good evidence that if you can do high frequency remotely, that should be able to provide a very cost-efficient solution. So there are a huge number of emerging solutions in population health and prevention that are emerging sort of in the NHS today. So some of these are companies on the National Innovation Accelerator. Some of them are companies in the NHS England Digital Diabetes Prevention Pilot. And then there is a number of companies in test beds and things like that. So there's a large number of sort of innovations happening in the NHS in different areas. And I think mental health has been going, probably actually going the longest. And now obesity, prediabetes, diabetes, COPD are all emerging as new areas where digital is being used to show dramatic impact in terms of improving population health and improving accessibility. So I would now want to move on to sort of Aviva and what we do. So we very much take that approach of a healthcare professional plus technology to enable maximising access to a population with the goal of improving people's health and living sort of healthier, happier and longer lives. So we've worked with about 25,000 people so far to improve their health, and we work sort of mostly with dietitians, and we work across a number of geographies. So we work across UK, Switzerland, Germany, France, and also in the Middle East. And there's very different populations and different challenges, but overall, everyone is facing the same kind of chronic disease burden and the lack of resources to offer face-to-face services to everyone. We're also the official technology provider to the British Dietetic Association, and we have kind of our programs and our approach has been developed and tested with NHS clinicians. And we've been hugely beneficial, hugely lucky to benefit from all of the programs that are happening in the NHS today to drive innovation. So there's accelerators, like the Digital Health London Accelerator and the National Innovation Accelerator. There are test beds, so we're working in the west of England and also in Sheffield as their test beds. And there's also lots of funding for new solutions to kind of try and tackle these prevention problems that we're very appreciative of. So there are 4 main things that we do, and I'm going to kind of pull out the detail of one of them, but to kind of give the example. But I just wanted to give an overview of sort of how we think about using technology in different areas. So pre-diabetes, we do a 12-month behaviour change program looking to help people reduce their HbA1c, lose weight and increase their physical activity level. Same in type 2 diabetes for people who've been diagnosed. And then we also work in tier 2 and tier 3 weight management. and also in medicines management as well. So it shows how incredibly broad the application of technology can be. We're working, from young people with pre-diabetes and young people with babies with cow's milk protein allergy to older people who are newly diagnosed with type 2 diabetes. And this approach can kind of work with all different groups. So we have a program called Diabetes Support that I thought would be useful to just go into detail to explain how we think about the different components and how we think it helps people and kind of what the barriers are. So the program itself was designed by dietitians, psychologists, endocrinologists, and diabetes specialist nurses. And we worked with a professor in Northern Ireland called Vivian Coates, who was commissioned by Diabetes UK to do research into the barriers to accessing structured education. And she came up with 3 kind of core pillars of how structured education needs to be different to maximize access. And we sort of integrate those 3 pillars into what we do. So one of them is understanding to what a patient is doing. One is flexibility, and the third is transparency of outcomes. So the program itself is 3 hours of one-to-one support with a dietitian, which can either be over the phone or via an app. And then there's 10 hours of self-study materials, which can either be a booklet or an online learning portal, depending on whether people have access to the internet. And we always take patients through a choice of what they want to do. So we would be referred by the GP, and then there's an initial activation call to explain what the program is. So today, for most programs that sort of diabetes education, you would just get a letter in the post saying you have been booked onto this program in this period of time. And very few people understand why they have been sent, what the benefits of attending are, etc., etc. So the first contact that we have with a person is with a health coach, explaining what the program is, why, how they could benefit, how it could fit into their life. And then we talk about how they want to access it. So we say, do you have access to the internet or not? Do you have access to a smartphone? And if they have access to the internet, they can access the online learning. If they can use the smartphone, they can use the app for self-monitoring. And if they don't, they can do the program as phone calls or having the printed guidebook sent to them in the post. And the idea is just to make it accessible sort of to everyone. And then they have a one-to-one assessment with a dietitian where they create an action plan for the future. They set a series of SMART goals that they're going to work on. And then it's a 12-week intervention or so that they go through where they have 8 one-to-one sessions with the dietitian. And then they go through kind of the key curriculum. And then that curriculum covers what the condition is, nutrition, physical activity, mental health, and then all of the aspects of living with diabetes. So that's things like insurance, travel, medications, all of those other things. So just to sort of talk about the technology that we use. So almost all digital health companies have a very similar sort of technology approach, which is you have an electronic medical record for the healthcare professional, you have an app or an online learning portal for the patient, and you normally integrate with wearables that can be used for people to help them kind of on their journey. And it's sort of accessible to people in whichever format they want to choose to access it. So a very big component of what we try and do is encourage people to use the app as part of their care. So on the far left, you see it is very much like WhatsApp. So it is sort of one-to-one support from a dietitian and designed to be kind of used by anyone for people to monitor their activity, their weight, and their goals. So there's lots of evidence in dietetics and behavior change if you self-monitor your behaviors. So if you regularly monitor your weight and monitor your activity, you're more likely to sustain your behaviors over time. So the app is for people free to use for the rest of their life after they've been through the program, and they can use it to self-monitor over time once they've got used to it, and they'll work through a kind of series of goals that they've been set with a dietitian. Then another component is sort of a learning portal. So it's an online platform where they go through all the different components of diabetes, and most of the content is in videos and podcasts. And the idea of this, again, sort of working with Vivian Coates, was to say different people learn at different rates, and group-based education is one session with one group set of content and no ability to refresh and replay and maybe stop someone and begin again. And it's very hard to work with different people at different rates. So the idea of having it all in an online or video format is people can go back, they can watch it as many times as they want, they can refresh as many times as they want in the future. So anyone who goes through the program has lifelong access to this, and we obviously update it kind of as new evidence and education comes out. So very importantly, what is the impact? So we have had nearly 1,400, actually it's just over 1,400 referrals to date now in the NHS. So of those referrals, 71% of people are enrolled onto the program, which compares to around 10% with face-to-face programs. And we think the key difference there is the engagement call. So someone is actually explaining to you what it is and why you should benefit and what you can engage. We monitor self-confidence before and afterwards. We monitor the NHS Friends and Family Test, and we monitor body weight loss, HbA1c, and benefits over time. So sort of people are achieving, so this is between 6 and 12 months after they've been enrolled onto the program, and this is just real world data. So we've not done it as a trial where it's the 6-month moment in time, it's kind of just following them up and seeing kind of what benefits do people get in the real world. So we're doing two sort of trials as such in the NHS, one in Salford and one in Somerset, to kind of have a bigger data set, and then looking at doing a randomized trial comparing this to existing face-to-face programs. But overall, we feel the results are incredibly compelling, and 26% of people achieving remission of their diabetes at 6 months shows that people can have a really big impact on their health. So if you are a commissioner or someone paying for prevention services, the question then is, well, what benefit do I get for that reduction in HbA1c? So there was a study in Scandinavia back in 2008 that showed that you have really huge impacts in health from an 11 millimole per mole reduction in HbA1c, so reductions in microvascular amputations, macrovascular problems, deaths, heart attack and stroke. And so these programs, so a GLP-1 medication or an SGL2 medication get around a sort of an 8 to 11 millimole per mole reduction in HbA1c, and they cost between £500 and £1,000 per patient per year. Whereas this program is £150 for a patient to go through once. So from a cost efficiency point of view, it makes much more sense for us to be putting money into prevention rather than into expensive medications. So when we think about the benefits for the health system overall, and this is not just us, this is any digital behaviour change intervention in terms of how it can help beyond existing face-to-face services, is improving access in people that are hard to reach. So in diabetes education, that's in particular men, people who work and BME groups. And then there is evidence that people who have a low PAM score, so patient activation measure is something that's being increasingly rolled out, looking at how activated are people to look after their health. And there's evidence that people who have lower PAM scores are less likely to engage in behaviour change programs. And so the goal, again, of the activation call is to sort of to understand people's current motivation and to understand if they want to sort of engage in a lifestyle intervention and how it could help. Obviously, there's efficiency savings, which is all around non-elective admissions, outpatient appointments, primary care visits, and prescribing costs. And then the last piece is very much around quality. So diabetes uptake and diabetes education uptake and attendance has been included in the new CCG improvement and assessment frameworks. And so kind of as an emphasis from NHS England that this is a really important thing for people to be engaging in and helping prevent future costs. And so obviously increasing access can help with that. And then obviously QOF targets and the overall prevention agenda. So I want to just sort of talk quickly about two examples of where we've kind of seen this work that's been really great to be part of. So in Buckinghamshire, they have created an integrated adult wellbeing hub. So it's a single point of access for GPs to refer to for people with long-term conditions. So it can be things for weight management, it can be for mental health, it can be for stopping smoking, and it can also be for diabetes. So the GP, and it's sort of co-funded between the CCG and the council, very much working together. And the idea is that any person with a long-term condition can be referred into that service. And then in that service, in diabetes education, there is a face-to-face option, there's a remote option, and then there's a digital option. And the idea is that people can have a variety of choices. And it would be fantastic if everywhere there were similar services where there was a place where people could talk about what is suited for them and in order to sort of maximise access. And that's a partnership of Buckinghamshire Healthcare Trust, Oxford Health NHS Foundation Trust, Parkwood and Aviva, and obviously the CCG and the commissioners. And then in Wakefield, there's a very similar approach in Tier 3 weight management. So again, the CCG and the council working together, they have got a single point of access for complex obesity, and people are offered a combination of face-to-face, remote and digital options. And that's us working together with sort of Mid-Yorkshire Hospitals NHS Trust. So as you can see, a real focus here is how do we complement existing face-to-face services and how do we increase capacity of their team to kind of support the population at scale. So what I wanted to sort of close on was really just having a bit of a discussion. It's a very full room, so I don't know exactly how we can go about doing this. But I guess sort of a question back to people working in public health and also in CCGs. Do you have any examples of where you have included digital into the options that are available or remote options? If so, what were the barriers? How did you kind of go about it? There's sort of common questions around equity, around local provision, around information governance. And then also thinking about if you're in an area where this isn't the case, how could you think about the wider aspects of things to consider commissioning it? So is anyone willing to speak about their experience of commissioning digital innovations in their services and what the challenges have been and how they found its impact to the population? I might pick on someone in case. Yeah, go ahead.
So, my name's Julie Powell. I work in Westborough Barnet. We've been commissioned by CCG to deliver a wellbeing hub. It's an integrated system where we between health, social care, mental health. And what's happened is that the CCG have commissioned the local mental health trust to employ some link workers who are mental health clinicians and locate them into private care settings. And then they've also done some work with local community centre. I'm chief executive of the local infrastructure organisation, and we've got a pool of local voluntary community organisations that can offer support to people who come in with emotional wellbeing needs. They have something called the emotional health check, and then have a wellbeing plan, and a signpost and was reported to some support from local organisations. But what we've also done is developed a webinar programme which is supported by, which is done on a digital platform and supported by clinicians, is HiAP compliant. And we're running a portfolio of about 6 programmes which are around, which are sort of around low mood, depression, a whole load of programmes. And what we're trying to do is we tested it out over the summer and ran it in a local community workshop, because one of the things we're really clear about in terms of mental health is that sense of isolation. So we thought we'd get people in a room, they could actually be doing the webinar programme together with a clinician, and we've got a psychological wellbeing practitioner on hand to offer support pre and post the session. So it's been really kind of interesting, I think, in terms of what we're hoping to do. And the idea is that we're working with the voluntary sector, with the mental health trust, to actually get people into that
Sorry, can I just ask, can everyone hear what she was saying? No. Is there a microphone that we could have to go around? Because I guess, so the question that I was going to have is, what do you think was key to the success of that approach being?
For me, key success factor was actually the CCG taking a very international leadership role. So what they did was they had a new mental health commissioner and they had transformation leads. And what they did was they basically created an environment where they got a whole load of stakeholders together to get them to ask them what they thought about current mental health provision. And so there was a cathartic process of about 6 months where they had these breakfasts where people complained about the system. And then what the CCP said was, okay, we're now going to embark on the Trailblazer programme, and what we want you to do is identify solutions. So it's about using co-design and co-production in a really constructive way, and actually saying that the local voluntary and community charity sector had a really, really important part to play in terms of delivering an early intervention prevention offer. So what we're doing is basically front-loading the system so we could access people who were feeling a bit wobbly but may not necessarily be eligible for statutory thresholds of care. The other challenge in the system was that there was a real bottleneck because people were not able to access step 2 HiAP services from the mental health provider at the time. So there was just this massive blockage, and because of the population profile, it's the largest most populous London borough in terms of NHS England's mental health expectations around providing mental health services. There was a real anxiety around CCG, and that Barnet was basically not going to be meeting those targets. So it was a combination of things, but I think it was CCG being really taking a risk with the sector because they didn't have a historical relationship with the local voluntary and community sector. And then there were enough of us in the sector who were saying, we'd be interested, we'd be happy to give it a go. And it was just that kind of synergy that's come together.
Great, and I think that was very much our experience in terms of it's basically bringing all of the right people into the room to have the discussion around what the existing provision is. And I think the success, for example, in Buckinghamshire has been we've always worked very closely with the face-to-face provider to understand, how things are today and how do we kind of increase that access. I think because it's such a big group, what I might just say is just do some questions, and then if people want to do kind of open discussion bit afterwards around what's working in different bits, there's like a few of us here that we can kind of go through. So, questions? Finally.
Hello, hi. So I'm Tim Marshall, I work for Arthritis Research UK. So with arthritis and musculoskeletal conditions, similar burden of disease, cost to the NHS, etc. But what would you say, like with your physical activity resources, do you do to address multimorbidities? So people that might have diabetes and an MSK condition, for example. So it's not just that they're not exercising, it's that it's painful to exercise, for example, or they have limited mobility.
So I think we've recognised that physical activity is actually one of the hardest things to address in, for example, in the diabetes population and also in tier 3 weight management, because you have a huge range of what people are able to do. And because of their health conditions and also quite a few people having multi-morbidity. The interesting sort of question is, so what the simple thing that we can do is kind of create videos and content based around different staging for different people. So if you look in the physical activity module of our program, it guides you through to how active you are today and what your limitations are in terms of what activity you can do, and then it recommends a sort of a regime for you based on your current level of activity. And I think all we can do is just continue to increase the resources and development. There is a digital solution called PhysiTrack, I don't know if you've come across it, but so PhysiTrack is a really great solution. So it's basically an online a program where you can give people exercises tailored to what they can do and what they can't do, and it's almost like an exercise prescription. And I think one thing that we could do is look to work more with companies that do that, because I think everyone ends up specializing in their area of interest. We probably spend too much time thinking about nutrition because most of the people that work for us are dietitians, and that's what we know and we're good at. And there's a question about how do we add in those other components, but we try as much as we can.
Jill Rasmussen, GP. I wonder if you thought about, in the future, you could imagine patients with long-term conditions having multiple apps and multiple sensors. And I understand in the care of diabetes, there is a sensor you can put on your arm to measure your HbA1c levels.
Yeah.
There's also an interest in linking people's risk for depression and anxiety for long-term conditions. So including in what you provide are sort of the two questions about depression or anxiety, or the GAD-7 and PHQ-9, and linking that with a prompt maybe to self-refer to HiAP and also the sensor. So I wondered, how you thought about you were going to progress this and the impact on the patient about monitoring if they got blood pressure, MSK, diabetes, and mental health problems.
Yeah. So I get there's kind of two answers to that. So one is we always think how we fit into the local health economy. So for example, in Wakefield, every single person who is referred into our Tier 3 weight management service, we do the GAD-7 and the PHQ-9. And depending on their scores, we advise them to self-refer to the local HiAP service. And there's also a psychologist that's part of the service themselves. And so we very much think around holistically around what other services could that patient need. And so, for example, in the diabetes education program, it could be referral to exercise and referral, or whatever it may be around the local services. And so even though our service is fully remote, the dietitian will be either in or very aware of the local area. So they'll know about existing services and signposting, because we don't want to replicate services for the sake of replicating services. So it's around understanding the local health economy. From our perspective, I think the biggest thing that we recognise in diabetes and weight management is that mental health is a key component of it. There are quite a few online and digital interventions for mental health. There's one in the Netherlands and there's one in Germany that have multiple clinical trials showing their effectiveness, and we're talking to them about integrating them into our platform. So basically patients would be able to access those as part of the care pathway. There's obviously the challenge of reimbursement for that, and obviously there's a completely different pot of money for HiAP services versus diabetes services, which is challenging. So I think from a technical aspect, it's actually not hard. Like, it would be very easy for us to integrate those solutions and offer them both to the person, depending on need, because it's just doing questionnaires. I think the biggest barrier to that would be the funding, and a separate question, because you would have to go and engage the mental health, the commissioners involved in mental health, and the opportunity when you have that integrated budget where you commission everything at once and you think about the digital solutions and how they fit alongside might be a way of overcoming that. So I would say it is not a technical problem. It's how do we think about looking after a patient, and how do we screen that patient appropriately or the person appropriately when they come into a service. Because so Buckinghamshire again do this, where anyone who's referred into the single point of access, they have an initial motivational interviewing coaching session where they ask about what services they want to access, what they feel their challenges are. And that kind of patient or population health coordinator, I think, is going to become increasingly important to help people access the right service for them.
Thank you. I just wanted to pick up on the point you mentioned in your question around equity, because obviously thinking about that earlier in the day, and I was just interested in the evidence that you were describing at the beginning, whether we know whether there is equity impact in relation to these interventions. So, for example, do we know if these types of digital interventions have different outcomes according to people's circumstances, and whether there might be any intervention generated inequalities? And if so, is there a way of getting that more into the evidence base?
We actually commissioned a piece of work in Germany to look at what are the predictors of whether, so we do face-to-face services. So we're really just a dietetics company, and we do face-to-face services, and if people want to use the digital, they can use the digital. And we commissioned a piece of research to look at what were the predictors of people choosing to use the digital solution. And the only predictor that was significant was age. So basically socioeconomic status, gender, educational status, all of those other things actually weren't predictive of whether or not someone chose to use digital as part of their care. That's obviously just a choice point rather than an outcome point, but we thought that was really interesting in terms of, it seems to not necessarily matter beyond age for whether or not you choose digital. From a equity access, I think there is definitely a question of whether or not people have access to things or not. And that is why we do phone calls and a printed guidebook sent to your home so that everyone can access this service no matter what. And the service is tailored to you depending on what you need. And I think digital is the answer is definitely sort of not the answer. There is definitely 20% or so of the population who will access digital, but we very much believe that you have to support people to do that, and you have to offer people an alternative. In terms of research around what different groups access different solutions, as far as I'm aware, there really isn't any. There really hasn't been done. There is things like the Wish Foundation who do lots of research in terms of digital engage, in terms of being able to access digital, and there's definitely groups of the population that can't access digital, but I don't know if people have looked at the impact of that. And that's why we very much try and describe ourselves as a remote behaviour change provider rather than a digital behaviour change provider, because the idea is accessible to everyone.
Right, thank you. Super interesting. Conscious about the push and for social prescribing, and as you sort of said, although we had examples about diabetes, that your core business is about dietetics, how are you linking into the social prescribing movement, which is certainly in London now, it's Sadiq Khan's #2 health priority, is growing fast. So there's one question about that. The other side I was interested in is the link with employment, and any recommendations or support you give to your users about how to change working environments to keep people in work for longer and also adjust how they are at work in order to achieve some of the behavioural changes you've described.
So on both questions, I would say I'm definitely not the expert in terms of, so I would ask, so on the second piece around work pace and alterations, I will get one of our dietitians who might be in the audience or might be outside to talk to you about that side of things. From social prescribing, every discussion I've always sort of ended up being in is what budget does that kind of sit in, and having a kind of a diabetes is not in the social prescribing budget, and therefore how does those two things fit together? And I think I would love, but dietetics might be, exactly. But again, so the way that dietetics is commissioned is it's normally as a block contract with the community provider or the acute. And the reason why we actually mostly work in diabetes is because they have historically been commissioned separately to dietetics. So, and if we tried to say that we were going to deliver dietetic services, the local community trust or the acute trust might say, well, that's what we do. And they wouldn't be seeing it as a kind of an enabler. Whereas in diabetes, because of things are being commissioned differently, it's been a kind of easier discussion. We would love to talk about how we could enable the dietitian workforce and kind of working with hospitals. We actually sell our software to hospitals to use in their dietetic departments. And so when they're paid by block contracts, that's fine. But in most trusts, they're paid under PBR, and there's no tariff for remote care. And so instead of being paid £100 per outpatient appointment, as most London trusts are, if they do a remote appointment, they get paid £29. So they basically say they have no incentive to adopt digital because they just earn substantially less money for the same care. I know some trusts have been able to negotiate that with the CCGs and come up with a new tariff, but it's a huge number of things to go through just to be able to use digital in your service. But yeah, we would love to learn more about how we could do that in dietetics. Great. Perfect. All right. We're around for any questions. There's other people from my team as well, so come around. Thanks very much.